Introduction to Nursing Concepts, Nursing Process Part 1. This is Martha Olson. The role and responsibility of the RN is what we're going to be talking about in this PowerPoint and how it differs between the RN and the LPN. The definition of nursing is listed here. It was actually updated in 2006. It's on page 1 in your Potter and Perry book, and it just gives the definition of what we think nursing is. The role of the nurse is varied and has many influences, one of which is society. When I go to work, I don't fulfill any one of those, but probably all of them. Our scope of practice is good to know because it's important that we know and apply these standards in our practice every day. Page 4 in Potter and Perry talks about the quality of practice. We need to have the education to reflect current practice, and with that, we think of that new initiative for the RN to BSN. Collaboration and collegiality, where we interact and contribute to the profession, maybe being part of the American Nurses Association, maybe being part of Iowa Nurses Association, continuing with research. So everything we do, we want to promote the field of nursing in a positive light for society. Education is confusing to the public because a lot of people will say, I'm a nurse, but they don't say, I'm a nursing assistant, I'm a registered nurse. So we need to make sure that our name badges clearly identify our level of education, and also that we fall within that scope of practice for what we are educated to do. Page 5 of Potter and Perry talks about the National League of Nursing is that accrediting council. In 2008, they published the standards and criteria that are the core competencies for that professional nurse. Most programs today require the CNA before admission into any nursing program for many reasons. One is those basic skills, but also, and as important, is then that nurse understands the role of that certified nursing assistant and becomes more of a team player when they work with CNAs under them. The LPN is a technical 1-year program. The RN is either a 2, 3, or 4-year. The 2-year is called the ADN or associate degree. The 3-year is a diploma, and the 4-year is the Bachelor's of Science from a university. As I said, there's the push for the BSN to be that professional nurse and that entry-level nurse, and we will just have to follow up with what is being done legislatively regarding that. The advanced registered nurse practitioner is now going to have to be a doctorate, and then your MSN is a master's in nursing, and you usually have to have a bachelor's in science in order to be able to go back to school to get your MSN. Delegation is that transfer of responsibility for an activity or a task on page 281 in Potter and Perry. It talks about results in quality patient care, improved efficiency, increased productivity, and then also empowering staff. We will be doing some delegation activities to practice how we go about doing that. We have to be good at priority setting. We have to be organized. We, as the RN, then have to decide what is appropriate to delegate. It would never be something that we dislike doing or we don't want to do independently, because that causes negative feelings. When you come out of a room and you ask the nurse aide to go in and get the person on a bedpan, that's a negative feeling for them, because it's like you're too good to do it yourself. Things that we are not able to delegate: assessment, diagnosis, planning, and evaluation in that nursing process, because those require nursing judgment, which the CNA has not been educated to do. Our 5 rights of delegation then are to make sure we delegate the right task. We would never ask a certified nursing assistant to go in and flush an IV, because that is not within their scope of practice. The right circumstances: if your patient is having very labile blood pressures, you would not want to ask somebody to go in and do a blood pressure for you, because you need to monitor that and use your critical thinking. So all of those are listed there. Communication is very important as we delegate. When I delegate to a certified nursing assistant, I need to make sure that I give them very clear, specific directions as to what I need done on what patient, when it needs to be done by, and then also what they need to come back and report to me. if the vital signs are all within normal and it's in the scope of practice and in the ability for that nurse to chart those vitals in the computer, I would hope that she would come back and at least give me what vitals were obtained and that they had been charted. When performance does not meet the expectation, they have probably had inadequate training, or maybe we've assigned too many tasks to them to be able to do it correctly. So as we delegate, we need to follow up. We are the nurse that retains responsibility for that patient and that task that has been done. So it's ultimately our responsibility to follow up to make sure that it got done. A big part of that is knowing who you're delegating to. How long have they worked there? How comfortable are they in that position? Do they have the knowledge and skills to be able to delegate that task to them? And then, as I said, communicate clearly and often with a lot of follow-up and provide feedback working as a team. In health promotion then, remember, nursing is very unique in that we have the opportunity to promote wellness in many, many ways. And as we look at the future of what a nurse will do, this is a big part of healthcare. Because anytime that we can do primary prevention, we save a lot of healthcare dollars and our society is healthier overall. On page 65, Potter and Perry talked about that in the 1990s it began with that focus more on health promotion and disease prevention. Some of the positives for that would be things like immunizations, nutrition, exercise, and negatives of health promotion, things like smoking, drinking alcohol, high-fat diet, or people that do not take their medications as they're prescribed. Cost containment and advanced technology. Nurses are going to be that vital link to improve health for the people that we are working with. The health belief model then is broken down on page 66 in 3 different ways. Number one, that risk of coronary artery disease. It runs in the family, and they know that, so they would know that I'm at high risk because of the genetics. The second one, the seriousness, they may not see heart disease as a problem. And so if they aren't taking it seriously, they probably are not exercising and altering their diet. And then under number 3, will they take action? That depends on their perception of the benefit of doing it and maybe barriers. Maybe this is a person that doesn't have the money to join a wellness center or to buy foods that are lower in fat. Variables that influence health are listed. You've had growth and development class, and that is where we see some of the internal developmental stages being talked about. Intellectual background is that knowledge, that cognitive ability. Is the person mentally able to influence their own health? Their perception of functioning, how they perceive their health. Emotion is such things as depression, fear, stress. Our spiritual factors are things that are integrated in people's lives. Family practices, a family that tends to stay healthy, eat healthy, exercise together, get annual screenings and wellness exams is part of just that family's culture. Socioeconomic factors are things like marital status, their habits, perhaps their occupation. If they work in the coal mines and they have, poor lungs because of breathing that all day. If they enter the healthcare system is a big one. I remember a lady that had very advanced breast cancer when she was admitted for the first time, and she said she had felt the lump in her breast for over a year, but not having health insurance, she did not seek medical care because she knew she couldn't afford it. So by that time we had passed the stage where we could have done a mastectomy and prevented that cancer from being metastasizing out to the body. Cultural background is talked about on page 70 in box 6.3, and as I said, a lot of risk factors go in with that, including stress. We know that stress threatens mental health as well as physical well-being, and it interferes in all phases of the healthcare system. Our levels of preventative care, this would be a good place for a question as you look on page 72, table 6.1. Our primary is that true prevention. It's eating and exercising to prevent getting diabetes and hypertension. Secondary prevention is having some health problems and we're at risk for further problems. And so maybe we are pre-diabetic or a diabetic and we decide now we need to get a low-fat diet and start carb counting. And then tertiary prevention is that disability. They've had the stroke because they've been a diabetic and not followed what they need to. So now we do rehab and we do what we can then to work with that person. Our legal and ethical issues, our code of ethics for nurses is in Potter and Perry, chapter 23. Our sources of law are statutory law, regulatory law, and common law. Statutory then is your civil, which is assault, battery, false imprisonment, and it protects the rights of individuals. Regulatory law, the Iowa Board of Nursing rules and regulations regulate the practice of nursing. And our common law is decisions on individual cases such as negligence and malpractice. Our code of ethics for nurses, what is right and wrong? What type of nurse will you be? Will you admit to making a medication error, or will you try to hide it so you don't have to make an incident report? We do have ethical obligations to the profession of nursing, which we need to keep in mind. To keep current, to keep continuing to learn is important. As nurses out working, we need to remember to help student nurses because we have to remember we were one also. To make nursing a positive image in the public. So how we dress, how we talk, all of that is part of that code of ethics. The Nurse Practice Act is regulated by the Board of Nursing, and each state has a different set of rules for their nurses in that state. Their number one purpose is to protect the public. They do not want the public getting hurt because of unsafe nurses. On page 296 and 297, it talks about the rules and regulations, the minimum education, what certifications nurses have to have, how many hours of CEU in order to maintain their nursing license is part of that. The Patient's Bill of Rights are listed here. This was passed in 2001, and it helps us to be able to put that patient first, to give them the rights as they are admitted to the hospital, so that we can't turn away somebody from an emergency room just because they don't have insurance. Our ethics and values are listed here. When we look on page 298, the right to refuse or autonomy. That was the case in 1986 where, because of religious reasons, Jehovah's Witnesses did not want a blood transfusion. The exception to that is children or minors, because we are trying to protect life and protecting third parties that are innocent. And so that went to a court of law, and that's how it was decided. Our advanced directives are such things as living wills, healthcare proxies, durable power of attorney for healthcare. It's important we understand each one of those. That living will directs treatment. It directs what medical procedure a person that's terminally ill wants. And so if somebody has a living will, it describes in there what exactly they do or do not want for further treatment. The durable power of attorney or healthcare proxy then designates a person to make healthcare decisions for them. So if it's somebody that has Alzheimer's and they are unable to make healthcare decisions, perhaps their son or daughter or spouse has been given the title then of durable power of attorney, and they will then make decisions related to their health care. This is all in chapter 23 in Potter and Perry. As we look then at some of our legal considerations in nursing practice, they are talked about in chapter 23 on page 301 and 302 as intentional or unintentional torts. Our negligence and malpractice. Negligence is failure to do something that an ordinary nurse would be able to do, where malpractice is professional negligence, not doing something that we should have done. On page 302, common negligent acts are things where we owe our duty to that client, but we didn't carry out that duty. So if a typical nurse would do vital signs every 1 hour on a patient in telemetry, and the nurse didn't do that, that would be negligence. Avoiding to follow the standards, the minimum standards that would be expected for that nurse. This ends our first session. I will continue with part 2.